Good morning, good afternoon, good evening, depending on which part of the world you are now. Welcome to the second session in the ATS and Union joint webinar called TB Elimination, Why Not Now? So my name is Annette Treiman. I am a professor at the Federal University of Rio de Janeiro in Brazil. I'm joined today by my co-chair, Kate O'Brien from the National TB Controllers Association. I would like to thank the American Thoracic Society and the Union for their collaboration on today's webinar, as well as our distinguished panel of speakers, providing their insight into TB elimination. So before we start, I have a few brief notes and reminders. Firstly, we have muted all participants due to the large number of registrants. But if you have a question, you can submit it via the chat feature on the webinar platform at your right. Also, please note that this webinar is being recorded and will be available to all registrants. The archived webinar will also be posted on the ATS website. So please feel free to share the link with your colleagues. The aim of today's webinar, the second in a series of 4, is to discuss the role of prevention on the road to TB elimination. And with that, I'll turn things over to Kate to introduce our speakers. Thank you.
Thanks, Annette. This webinar will feature 3 speakers addressing a wide breadth of TB elimination topics. Our first presentation, There's Nothing Latent About Latent TB, will come from Dr. David Lewinson. Dr. Lewinson is a professor of medicine at Oregon Health and Science University and the chair of the ATS International Health Committee. Next, we'll hear about the upcoming vaccine pipeline from Dr. Ann Ginsberg. Dr. Ginsberg is the Deputy Director for TB Vaccines at the Bill and Melinda Gates Foundation. And after that, Nanette Mbote from Treatment Action Group will present on making prevention a priority. Following all presentations, we'll have a discussion among all the presenters. So please submit any questions you may have through the chat function. All right.
Well, hello. My name is David Lewinson, and I'm very pleased to be presenting today with the theme of There is Nothing Latent About Latent TB. For this presentation, I have nothing to disclose. So to start off with, I'd like to give you the take-home messages of this presentation. The first, and I think foremost, is going to be the concept that subclinical TB is TB. I also want to kind of follow up with many of the themes from our most recent session. This is, I think, a figure that was already shown in the prior session, but I think it's really impactful. And what it shows, and this was done in the Yukon-Kuskokwim area near Bethel, Alaska, and this is the result of many years of very aggressive intervention, which included treatment for latent TB, aggressive case finding, and very, very carefully managed treatment. And what you'll see from this slide here, we're looking at the prevalence of skin test positivity over time. And you'll see that when this studies began in the late 40s, early 50s, that nearly 50% of children who were 2 years of age had a positive skin test. And by the conclusion of this study in the late 60s, 70s, you can appreciate that virtually none of them had TST, and a reflection of essentially greatly diminished TB transmission that occurred during this time. Now, you might argue that given the fact that we actually have an approved vaccine, BCG, and most importantly have had effective drug therapy for TB dating back to the 50s, you would think that we would have eradicated TB, and yet the opposite is true. This data, actually provided by the World Health Organization, looks at the global trend in the red dotted line, and this trend is almost certainly made worse now by the prevalence of the COVID epidemic. And you can see that our goal is both by enhanced implementation of what we do currently, as well as by the development of tools. The hope was to actually eradicate TB by the year 2035. Now, clearly what's needed here are going to be better diagnostics, including point of care tests to help us identify those at risk, safer, easier, and shorter regimens for TB, safer and more effective treatment for latent TB, and effective pre and post vaccines. I also want to point out this modeling that was done by David Dowdy at Johns Hopkins University, and what we call here the cost of inaction. So this red dotted line is the same curve that I just showed. And what this highlights is that if we invest in new tools at a certain point in time, you can see the curve begins to decrease. But if we fail to make those investments, we don't see that decrease, and this cost of inaction simply increases with time. And this modeling by the Abu-Radat et al. Done in PNAS in 2009 simply highlights the idea that if we truly want to eradicate TB, we're going to need one of two inventions. One is vaccines, which Ann Ginsberg is going to be covering, and the other is actually treatment for latent TB infection. And this simply shows that if we either look at incidence or mortality, that we have a dramatic effect on the prevalence of TB by effective LTBI therapy. So I'm going to start now with the natural history of TB circa 1995. And I think we had really a number of discrete possibilities. The first, we knew that TB was spread via aerosol, leading to active TB, in this case, a kind of classic X-ray with cavitary upper lobe disease and presumably positive smears. But from here, things really got quite complicated in the sense that we really have no direct way to measure TB, so that we presume TB is latent, but this is really indirect as if we're measuring a response to TB antigens, in this case, the tuberculin skin test, and more recently with the interferon gamma release assays. So really, what accounts for the persistence of TB? I think oftentimes we know there's a huge reservoir, and it's been estimated that about a quarter of the world is infected with TB. We know there can be prolonged periods of transmission that are often either minimally symptomatic or asymptomatic. We certainly know that HIV has compounded this. And interestingly, all of the currently unanswered questions in TB are the exact same ones that motivated me as a pulmonary fellow. Where does TB reside in the body? I think we always presume it's a granuloma, but it's really unclear in those who are considered to have latent TB where it resides or if it resides at all. Can TB be eradicated? And finally, who is really at risk to get TB? Now, I'm going to start with this very old data, but I think it really makes the point, because I think most of us have heard that roughly 5 to 10% of people will develop TB following their lifetime exposure. But I think these two studies actually really make that paradigm a little bit unclear. So these are both control populations, one from the preventative INH trial that was taking place in Bethel, Alaska, and the other, the BCG trial that took place in the UK. So this is really the natural history of TB following exposure in a household contact. And what you can see in the first 2 to 5 years, we see the predominance of TB occurring in those first couple of years. And then we see this rather long tail, and this is really considered to be a lifetime risk. But as I think about the slide, it really is problematic. The first is that these were both considered to be very high prevalence areas of TB, which means that the possibility of re-exposure and reinfection really couldn't be ruled out. Now, we do know that persistent TB and reactivation can occur, and that's certainly a driver of TB in the United States at present, but it certainly makes the argument that there's really nothing about latent TB. One would have to argue that this first few years is really more about acute TB infection. Now, to kind of highlight this, I'm going to highlight a couple of really nice studies. This one of the early studies that came out of Robert Wilkinson's group. And what they did was to use PET CT scanning to look at patients who actually were considered to be latent TB. These were HIV-infected subjects who were smear and culture negative. And what you can see here, I'm just giving you 4 different instances, are PET CT positivity, which you can appreciate here, you can appreciate here, and here, which in some cases actually resolves with INH chemoprophylaxis. So as this is a marker of inflammation and not bacterial burden, we can't know for sure that this is where TB lives, but it certainly would argue that at least in these cases where people are considered to have latent TB, there's ongoing inflammation that seems to respond to therapy. And I think from this and many other studies, we developed a more nuanced view of TB infection. And this really starts with exposure, and it's certainly possible that there are many cases where following an exposure, such as in a household contact, that we never see priming of antigen-specific T cells, and we would consider the possibility that these people were either unexposed or actually cleared the TB as a consequence of innate immunity that couldn't be observed. It's also possible that even those who develop a positive adaptive T cell response may have eliminated the infection. It's also possible that people who developed a similar response may harbor the bacteria in what we consider a quiescent phase. And then finally, we move across this red dotted line essentially into TB. That is either people who have active bacterial replication, which may be maintained at subclinical levels, but this will still be an active infection, or those who have full-blown TB disease. This is just to highlight one study, and I think we're beginning to appreciate the fact that there are really many different ways that we can actually categorize folks as having subclinical TB. So this is a really beautiful study that was done by Jyoti Rangaran and who's at Atlanta. And what she did here is to look at either patients who were considered or subject considered to either have latent TB or active TB. And what she looked at were cellular markers of activation, in this case CD4 T cells that either expressed class 2, the marker CD38, or the marker of proliferation of Ki67. And what you can see in its case, that these proliferating T cells, in this case in response to ESAT6 and CFP10, could actually really clearly delineate those with active TB from latent TB. Now, this is just really one of many studies that have looked at cellular immunity in this context. So things that may go down, and I'll describe in more detail, are things like interferon alpha, interferon gamma, in some cases activated CD4 T cells and CD8 T cells. And things that may go up are things like NKT cells and MATE cells. So you may say, but we already have tests for latent TB, either the T-spot TB or the quantiferon. And indeed, these tests are extraordinarily specific. The study I show here, which took place in household contacts across Europe, demonstrated a negative predictive value of well over 99% for the quantiferon, and as well as the T-spot TB. So the question then isn't the specificity of these tests, it really has to do with the positive predictive value. And it's been noted that to prevent one case, you had to treat roughly 38 or 37 cases for the quantiferon or the T-spot TB respectively. I do want to highlight the idea that there's quantitative information in the quantiferon that I think we don't take advantage of. There's two beautiful studies here that I want to point out. The first was done by Andrews and his colleagues in infants in the MVA antigen 85A trial. And what they noticed is that if you had an interferon gamma level of greater than 4 international units, the relative risk of getting TB was 42.5. So very, very significant. And similarly, in a household contact study that looked at 44,000 individuals from Norway, published by Winji et al., they used the TB registry to evaluate TB risk prospectively. And you can again appreciate that those very high values, that is greater than 4, had a relative risk of over 30. So as a clinician, paying attention to those very high values clearly places a patient at higher risk for getting TB. So the issue really then is really more about the product profile. That is, what are we looking for? I would argue that being able to treat or find 38 patients to prevent one case would be outstanding if we were talking about breast cancer or colon cancer. But in TB, of course, we're talking about treating many, many people prophylactically. And so I think that number is considered to be high and has led us to focus on groups at risk, such as young children and those with HIV. However, one can imagine a change in this scenario, which would really change the equation. So the first would be a test that's far more predictive. That is, you can envision that if we needed to treat 5 patients to prevent a case, we'd have a very different scenario. Or you could imagine that treatment, rather than taking a minimum of 12 weeks, could take place in a week, like a Z-Pack, and that would also change the equation. So it's really this balance, I think, between the number needed to treat and both the efficacy and duration of the therapy. So this really then gets at some rather exciting data, which I'm going to conclude with. So the first part of this was actually an interferon signature that was developed by Ann O'Gara and her group. And what they did, so this is an RNA signature that could be measured transcriptionally using peripheral blood, and I'll argue that this is a signature that's largely driven by neutrophils. And you can appreciate in the red over here, the signature actually clearly delineated those with active TB. And in fact, they could show that the stronger the signal was, they could demonstrate that the signal was stronger in those with advanced disease. And similarly, they could show that the signal actually decreased following treatment. The other thing that I'll get back to is that you can see in this group that was considered to have latent TB, you could see many that looked like they already had a signature for TB, and I'm going to come back to that as well, kind of raising the idea that the signature might actually be useful in delineating subclinical TB. So this is a really beautiful study that was done by Zach and his colleagues, along with his colleagues at SATV, as well as the GC6 consortium. So this is using a modification, or they derived a signature then from an adolescent cohort of about 4,000 subjects. And they looked prospectively. So that is, they took adolescent subjects and then look at them over a period of approximately 2 years. And you can see that those who were close to developing TB here, between 1 and 6 months, had a pretty strong signal from this transcriptional signature that then decreased as you got further and further from the time of diagnosis. And similarly, the signature actually diminished as treatment occurred, suggesting that there was a group of patients who were going to go on to get TB that we could detect using this signature. So what are the barriers? Well, first of all has been the complexity of the assay, and there's been a number of nice studies that have really tried to whittle down the number of genes that have to be measured. And the other is going to be specificity. So this is a really nice study from the O'Gara group that looked at the transcriptional signature across a number of different cohorts. The top 3 here are all TB cohorts, and again, you can see the excellent performance of this signature in delineating active TB from latent TB. But you can also appreciate that if we look at influenza, as well as bacterial pneumonia, that the signature is not entirely specific. I think quantitatively, it's typically higher in TB than these other conditions, but nonetheless, during viral and other bacterial infections, the signature is not fully specific. And of course, with COVID, this is especially concerning. And it's going to come back to the point that the signature is not a standalone. That is, it's have to be considered in the context of the prevalence of TB in that population. So I'm going to briefly describe a study that was actually done by Tom Scriba and Mark Catherall and their colleagues at SATV. This is a really beautiful study. And what they wanted to do was the following. So first of all, as I've mentioned, all of the studies that I mentioned previously were based on case control studies. So their goal was to evaluate prospectively unselected adults for the performance of this. They used what was called the RISC-11, which is an 11 gene signature as well. So they wanted to look at that diagnostic performance of this for subclinical and symptomatic TB. They wanted to look at the prognostic performance of this score for incident TB over a period of 15 months. And then finally, they wanted to ask, does treatment based on this score actually improve the outcome? So this is the study. It had 3 different groups. So the first group, group A, would be those who are correlative risk positive and were treated with, in this case, with INH and rifapentine using the 12-week DOT regimen. Group B is going to be observational. So these are patients who are correlative risk positive but simply observed. And group C are those who are correlative risk minus and would be observed as well. So as I mentioned, this was the strategy here was to look at the walking well. So they were not selected for any known risk factors. The biomarker in this case was the RISC-11 score. And the TB preventative therapy regimen was 3-HP. So I'm going to go ahead and walk you through this slide. This is the main results from the study. So this is looking at the probability of prevalent TB. That is those patients who were discovered during the course or during the enrollment in the study to actually have TB. And you'll appreciate that about 4% of those who are RISC-11 positive actually had TB, and just under 1% of those who are RISC-11 negative actually had TB. So these patients were then treated and then excluded from the rest of the study. And then what we're seeing now is the follow-up over time. In the blue is those who are RISC-11 positive, and in the green, those who are negative. What's really striking is that in the first 6 months or so, we began to see cases arising in those who are RISC-11 positive. And I think much like the ZAC adolescent study, I would argue that these were patients who probably had subclinical or smoldering TB that went ahead to TB during that time interval. And what's interesting then is that that discrimination really wanes after about 9 months. And you see that in the RISC-11 minus group, we begin to see this as well. And I think what this argues that this may be a reflection then of ongoing community transmission that we're beginning to see after that 9 months. What's I think really striking is that about 80% of the cases were actually asymptomatic. So I show this here. So these are the risk 11 score percentages. And you can see that people who are symptomatic, as I showed earlier, are much more likely to have a risk 11 score positive, but many who are asymptomatic had this as well. And of course, as I mentioned, there were certainly many patients or many subjects in the trial who actually had a risk 11 score that was positive, but nonetheless didn't have TB. So this is now looking at the diagnostic performance. What I'm showing here is the ideal and acceptable profile derived by the WHO for the target product profiles. And what you can see in red are the symptomatic groups, and here the diagnostic performance was really excellent. But in the rest, we're just a little bit less than what would be the preferred target profile. And this was true either for prevalent TB or for incident TB down the road. And if we look at treatment, what you can see is that treatment based on 3-HP did not have a statistically significant effect, either if we looked at the modified intention to treat analysis on the left or the per protocol on the right. So there's been some debate about why that might be. I think the kind of first obvious thing is that we've culled out so much of the TB at the early time points that I think we may have lost the power to really see the benefit. And the other, of course, would be that perhaps this is too short, that this regimen is too short in this setting. I think these are open questions. I do really want to thank Tom Scriba and Mark Catherall and their team. You can see that this was a broad team and a really powerful study. And I just want to conclude with a few some food for thought that maybe we'll have time to discuss. So I think the first is that by measuring the host response, we can clearly distinguish TB from latent TB. I think in many cases, the specificity of this assessment is going to have to rest on the measurement of TB-specific antigens. That is, it's hard to see having a standalone test that relies, for example, on interferon alpha in the absence of the measurement of TB-specific immunity. I think the Corda study really highlights the challenges in how do we best integrate these findings into prospective evaluations of the risk of progression. On the one hand, it was really surprising that you could detect a 4% prevalence of TB in people who appeared to be well. But I think we have to learn how these responses might be integrated into clinical decision-making and to public care. So with that, I'm going to go ahead and stop here. I want to really thank both the ATS and the Union for organizing this session. So thank you very much.
Hello, it's my pleasure to be with you today to talk about the exciting progress in TB vaccine development. Thank you to the organizers for including me in this interesting webinar. Why do we need new vaccines to prevent TB? Many other infectious diseases, most recently COVID-19, have demonstrated that vaccines are the most effective tool in reducing public health burdens and ending epidemics. But in particular, why do we need new vaccines for TB? Well, unfortunately, infant BCG, while helping to protect under 5-year-olds from severe forms of TB, does not protect adolescents and adults effectively, and is clearly not controlling the global epidemic despite its widespread use. Recent modeling from Richard White at the London School of Hygiene and Tropical Medicine and his colleagues have shown what an effective vaccine could do. One, for example, with just 50% vaccine efficacy. And he used India and China as examples, as demonstrated here. The y-axis on this graph shows all TB incidents over time, with the x-axis being time from 2025 to 2050. The blue lines indicate what would happen to the epidemic in these countries without any new tools, and in particular without a new vaccine. The yellow line shows if vaccine works only in those given to already infected individuals. So that's referred to as a post-infection vaccine. And the red line indicates what would happen to the epidemic curve if the vaccine works when given both pre and post-infection. As you could see, a 50% efficacious vaccine could have at least 50% effect in decreasing all TB incidents in both of these countries, despite the fact that the epidemic is quite different in character in India and China. An effective vaccine of this type would also substantially reduce the incidence of RIF resistance and MDR-TB in these countries. And such a vaccine, as indicated here, could reduce national TB program costs and be cost-effective under most situations. So an effective TB vaccine could add major value to current prevention efforts, and it would do so potentially in a number of key ways. The goal for these new vaccines is to be able to vaccinate all comers, irrespective of their LTBI status, to maximize their impact. They would have potential for long-term sustained prevention, even in high-dose of infection settings. They're being developed with 1 to 2 dose regimens for the most part, and of course, we won't know yet whether there might be a potential need for a booster, say every 10 years. Clinically significant side effects of these vaccines appear to be very rare and would have to be so to be licensed and recommended for use in what would be a healthy population. TB vaccines are also likely to work equally well, irrespective of circulating MTB strains, drug resistance, or sensitivity pattern, so could truly be given to all comers. In thinking about what types of TB vaccines would be most effective, it's important to remember that TB manifests in people as a spectrum, from exposed yet uninfected on the left of this diagram to asymptomatic latent TB infection shown in the middle, to incipient and subclinical TB, and to active TB disease all the way on the right, which of course is the most transmissible form. Vaccines may be effective in people pre-infection or post-infection, or ideally, as we saw in the previous modeling, in both groups of people. The vast majority of transmission is by adolescents and adults, because they're the ones who primarily develop active pulmonary TB. BCG delivered to infants doesn't adequately protect these age groups, and so has not controlled the epidemic. Therefore, adolescents and adults are the first priority target for new improved TB vaccines, as preventing transmission from these age groups will protect all age groups. So let's briefly review the really exciting recent progress in TB vaccine development. Many of you will have seen a slide of this type previously, this one from the Stop TB Partnership Working Group on New Vaccines, and shows the global clinical pipeline of TB vaccine candidates. There are at least 14 candidates that we're aware of currently in clinical development. 8 of these are in efficacy testing, that is phase 2B or phase 3 development, the 2 columns on the right. Unfortunately, we don't have time to go through each candidate in detail today, but there are some overarching points I'd like to make. First of all, please note that the colored boxes indicate the 4 different vaccine platforms currently in use. So the blue are virally vectored candidates, the tan protein adjuvants, and maroon and darker brown are mycobacterial candidates, either killed or lysates or live attenuated vaccines, respectively. It's also important to understand that some of these candidates are being evaluated as pre-infection vaccines against prevention of infection or POI endpoints. Some are being tested as post-infection vaccines against prevention of TB disease or POD endpoints, as you see in the small white boxes that just came up. Some are being evaluated as adjuncts to treatment or given at the end of treatment to prevent TB recurrence. So those are POR endpoints. And some of these candidates, as you can see, are being tested in multiple trials for multiple different endpoints. The candidate at the top of the column under phase 2B, DAR 901, is a killed non-tuberculous mycobacterial candidate, which recently completed a prevention of infection trial in MTB uninfected adolescents in Tanzania. It unfortunately did not demonstrate protection. But it was recently published, and you can read about these results in more detail if you're interested in 2020, the journal Vaccine. But now I'd like to tell you briefly about two positive efficacy trials that were completed in the last 2 to 3 years and really changed our view of what's feasible in the relatively near future in TB vaccine development. These were trials in the first case for BCG revaccination and prevention of infection trial, and in the second case for M72AS01E. I'm sure many of you are already aware of these results, but they're so important to the field that I think they're worth highlighting briefly again. So these are those two trials. The first, as I said, was a prevention of infection trial of BCG revaccination or a novel subunit vaccine, H4IC31, in each case compared to a placebo. So it was a 3-arm trial conducted in almost 1,000 quantiferin negative, HIV negative adolescents in Africa. And the primary endpoint was prevention of initial quantiferin conversion, and the secondary endpoint, prevention of sustained quantiferin conversion, which we believe is essentially a marker of LTBI. And the important result was that BCG showed 45% efficacy for a point estimate against sustained quantiferin conversion. And of course, not unexpectedly, had an acceptable safety profile. H4IC31 unfortunately showed less protection, if any, as it wasn't statistically significant, and therefore its development has been terminated. The even more exciting result came from the M72AS01E phase 2B trial shown in the bottom of this slide. Here, over 3,500, in this case quantiferin positive, but still HIV negative adults in Africa were randomized 1-to-1 to be compared to placebo, 2 doses 1 month apart in a double-blinded fashion. And the primary endpoint here was prevention of culture and/or expert-confirmed pulmonary TB. And M72AS01E showed almost a 50% vaccine efficacy point estimate compared to placebo, a statistically significant result at the 95% confidence level, and it demonstrated an acceptable safety profile. So what are the next steps for these vaccines? In response to these promising results for BCG revaccination, with BCG, of course, being a licensed, generally safe, and very inexpensive vaccine, a larger trial is now being conducted by the Gates Medical Research Institute to confirm those original results, as well as to further explore the immune responses induced by BCG, and ideally be able to validate any potential correlate of protection that's discovered based on the biospecimens collected in the trial we just discussed. If the trial results of this new trial are supportive, potential policy changes to recommend implementation in high-risk, uninfected populations will be discussed with regulatory authorities, and the target date for completion of the trial is early 2024. The M72AS01E vaccine candidate is a candidate developed by GSK and composed of a recombinant fusion protein made up of 2 MTB antigens and the GSK proprietary adjuvant AS01, which is also in the GSK shingles vaccine, Shingrix, and RTSS, the malaria vaccine. Having shown characteristics in the phase 2B trial consistent with its target product profile and with the WHO preferred product characteristics for preventive adolescent or adult TB vaccine, M72AS01E is now being further developed by the Gates Medical Research Institute for use in lower and middle income countries with high TB burden, including, importantly, scale-up process development and manufacturing. This is being done in collaboration with GSK, who will continue to supply the AS01 adjuvant. M72 AS01E is also currently being evaluated in a large phase 2 safety trial in persons living with HIV infection. And a phase 3 licensure trial is in preparation. For example, an epidemiology study in at least 10 countries over multiple continents is getting underway to support site assessments and capacity building for the phase 3 trial. And correlates of protection discovery is also underway, utilizing biospecimens collected for this purpose during the phase 2B trial. A correlate of protection, of course, would be the most impactful tool in terms of speeding up TB vaccine development. Now, I would be remiss if I didn't at least mention briefly that there has also been exciting recent progress in early stages of TB vaccine research and development. And that includes demonstrations in NHP models, 2 examples of which are indicated here, of more potent TB vaccine efficacy than had ever been demonstrated before, both published just in the last couple of years. There's also now, I'm happy to be able to say, BioNTech is trying to apply the TB mRNA platform that's been so successful in COVID vaccines for TB, and progress is accelerating in other ways to try to develop even better next generation candidates. So the key takeaways, I think, from the studies we've been discussing are that improved TB vaccines are certainly feasible, and several are already in late stage development. That getting human data is crucial for advancing TB vaccine development, even though we don't fully understand all aspects of the host MTB interaction and the host protective immune response. So clinical and upstream research need to be continued to be conducted in parallel in order to accelerate progress in this field. The BCG revaccination trial showed that there's a potential new use of BCG protecting high-risk uninfected populations from MTB infection. And the M72 AS01E phase 2B trial showed that subunit vaccines expressing as few as 2 MTB antigens can be protective, and that vaccines can be used to protect people who already would be considered LTBI, that is quantiferin positive, can protect them from developing active TB disease. And the M72 candidate is now actively progressing towards licensure, with a target of first licensure in 2028. This is a vaccine which we saw from the modeling fits the criteria for having the potential to have really substantial impact across the globe. There are also important lessons from COVID-19 vaccine R&D that need to be leveraged for TB vaccine development. And finally, it's crucial that we start preparing for success to avoid delays in implementation. And so one thing that we can do now is to get more input from all affected communities, decision makers, and key stakeholders, as well as to try to ensure that there'll be manufacturing in high burden regions, as BioNTech and the European Union recently announced that they'll be collaborating to do in Africa. So thank you very much. It's been my pleasure to share this exciting progress with you, and I look forward to the question and answer period. Thank you.
Good morning, good afternoon, good evening. My name is Ginulu Lynette Mabote, and I work with the Treatment Action Group's TB team, focusing on TB prevention. I work on a project called Impact for TB, which is trying to promote short course treatment in order to end tuberculosis. I come to this forum and find it quite serendipitous that the American Thoracic Society has coming together with the Union to address this very important topic. So how can we make tuberculosis a priority? Before I commence with my presentation, I wanted to give a bit of background in terms of myself as a person. I was diagnosed with childhood TB at the age of 10. I was healed. I had psychosocial support, I had food, I had love, I had a doc supporter, and I think I had all the essentials that everybody should have who have tuberculosis. Since then, I've had bouts of tuberculosis in my life. Every other year, I suffer from bronchitis, and it takes a very long time for me to heal. In March 2021, I was diagnosed with pulmonary sarcoidosis. I didn't even know what sarcoidosis was, but what I was told was that my left lung is completely depleted, and that I really need to focus on strengthening my right lung. So now I'm on steroids and I'm trying to live this life that is new. So for me, as much as I was treated for my tuberculosis at a young age, it has never left my life. So TB doesn't end at being treated for it. It changes the quality of your life, and it is a recurring problem, which is why we need to make tuberculosis prevention a priority. I have come to this presentation and I've laid it out in a few priority areas. For me, priority 1 is redefining latent TB infection and focusing on TB prevention. When we talk about latent, we make it seem as though it's not even a threat and that not so many people have it and we do not have to worry. Yet we do know that TB infection is a spectrum of risk and activity, both bacterial activity and immunological activity. Because of these spectrums, we need to try and prevent TB before we actually get to active TB. So we need to look at latent TB, incipient TB, and subclinical TB before we actually move forward. Because once we get to subclinical, we really find ourselves in a dangerous spot. People wonder why the HIV community has been doing so well in almost getting to their targets, the UNHLM targets for TB by 2022. I ask myself the question, but when I look at the WHO algorithms, I understand why. People living with HIV have to just present with the 4 or 5 in some guideline symptoms for them to be put on TB preventive therapy, whereas their household contacts or household contacts of those who've had TB have to go through a whole cascade of tests before they are put on TBT. We don't have a workable golden standard for diagnosing TB, and this is a problem that we need to fix. Where can we intervene? I actually took this slide from Dr. Madhu Pai's presentation recently at the McGill Summer Course. For me, it spoke quite well in terms of where the various interventions are, but it also broke my heart when I had to look at how many hurdles one has to go through in terms of getting through the systems and the tools in order to get to where we are. This slide shows how active TB case finding approaches need to start at the household before we get to the passive ones. But it seems as though we've switched things around and we're focusing on passive TB finding, where we wait for people to come to the healthcare facility, presenting with active TB, and then having to treat them, and then having to go through the trauma of having to treat them. One then asks, what does happen when you give people isoniazid preventive therapy? Well, as you can see in this slide, when it is not prescribed, it is not taken. But when it is prescribed, it is not adequately monitored. We've got weak adherence as well as completion rates. This is a slide from 2018, yet the scenario today presents as such. This project that we've been doing called Impact for TB, that was funded by UnitAid, was a 4-year project that is under the Orem Institute. It has now been given the go-ahead to continue another 2 years. Impact for TB will utilize this grant to catalyze global adoption and scale up of 3HP regimens, as well as other rifampicin-based regimens within a few countries. The 12 countries in which the project works are listed below here. And what was really unique, or what has been unique about Impact for TB, is that it has had community and civil society engagement at the center or at the core of its response. And this has really helped to galvanize countries and move guidance so that we can adopt better guidance that have got rifapentine-based regimens, so that we can move costing of those guidance, and that we can ensure that there is a lot of scale up of the newer short course regimens. We're looking at a scenario where next year, in 18 months actually, we need to present on where we are in terms of our golden target, in terms of our targets. These targets were set in 2018 at the UN high-level meeting on tuberculosis. It seems as though we're doing well where people are living with HIV are concerned, looking at 5.3 million out of 6. That is because we've managed to move that signpost, and that people living with HIV have really been prioritized in a lot of programs and have pushed for TPT. We're seeing slower progress in children, and we're seeing really, really dismal progress when it comes to household contacts of children under 5, as well as household contacts of children above 5. There really is no program, no progress that we're seeing where TB households are concerned and where HIV negative people are concerned. This is again another thing that brings me to the second priority. And this is a priority of interests, okay? So we're taking various positions and interests. TPT for people not living with HIV is not prioritized. Our positions and our interests are different. And this is where the crux of the problem is. Unless we start realigning these priorities, we'll still keep singing the same song even after 2022. The 2020 Out of Step report is a periodic report that is put together by Stop TB Partnership and MSF and looks at various areas in terms of 11 priority countries around TB. When they looked at short course TPT regimens, some of the reasons cited as to why countries were performing so dismally included the fact that there's not enough time to prepare for implementation. There is lack of funding for procurement. There is lack of funding for implementation, that the medicine is too expensive, that they were not aware of the WHO recommended guidance for short treatment. So there are many excuses that are being made at national level. And these excuses are the excuses that are bringing us back, and the excuses that we need to put forward, or the excuses that we need to take and turn them into reasons why we need to fuel TB prevention interventions. Priority 3 is that we need to do better risk assessment, screening, and contact tracing. COVID-19 has taught us so much in 18 months than what tuberculosis has taught us since it killed the mummy. We have so many tools now at our disposal, and these tools would work if we did a lot more better, if we did better screening, if we did better contact tracing. But we cannot, because in most of our countries, a lot of the TB programs are still using paper-based systems. The time has come to migrate to electronic data collection systems so that we have better and improved visibility of TPT at national level. Priority number 4, we really need to start integrating TPT into differentiated service delivery models. We've already seen this being happening in a lot of countries, and we've had great assistance from the International AIDS Society in assisting countries to define and to integrate these building blocks of TPT within the DSD models. What this basically means is that when a patient living with HIV goes to get their refills of ARVs, they also get their refills of TPT. This is a great way to ensure that we are integrating programs and that we are moving forward together. The 5th priority, I do not think we will get anywhere until we do better community engagement work. This is crucial in scaling up TB prevention. We have learned through Impact for TB that when we do proper, first, community-led treatment literacy, second, support communities with resources, that we are able to see scale up in the work that they do. As you see in this picture, we have brought a whole cascade of groups within the program, including people who use drugs, who are now being sensitized around the importance of TBT. Between mid-May and June 2001, the Treatment Action Group convened an online treatment literacy training, and we had close to 300 participants who were involved in that training, who now are equipped with the importance of TB preventive therapy. It is just unfortunate that we cannot fund all the cascade or the entire group so that they can now go and do national advocacy. But the movement is coming. We are building better, stronger. We will get there. At current point, I think we're moving at incremental steps. And yes, incremental steps will get us to TB prevention. But from our TB prevention efforts, we have seen that several questions need to be answered. Some of these that have been prompted are, how are we going to promote, scale up, and sustain short course TBT in existing models of care? How are we going to advocate for affordable access to rifapentine-based regimens? We definitely need to see improvements within TB infection treatment literacy levels at community and activist levels. Everybody that we've trained so far laments at how communities don't know about the power of TBT. A lot of the communities don't even take the medication that they get. That red pill that they get is a red pill that they put away. Yes, it is important for people to take treatment, but it's important for people to know why TBT is important in their lives. We also know that IPT-based regimens are not working. Those systems are failing at country level, and this is impacting millions of lives. So we definitely do need to either prioritize better systems that can adhere and monitor people on treatment, or we really need to give people short course therapy. We also need to prioritize TBT within the universal health coverage packages or agendas at national level. The question that I ask is, do we have time? Do we have the luxury to wait and work at the snail's pace to get to where we need to go? I don't think so. I think TB prevention is already becoming a global movement. I took the slide that was adapted by Dr. Jennifer Furin and Dr. Madhu Pai, called the Swiss cheese model for ending TB. As we can see, we need to tackle societal, personal, and person-centric health services in order for us to end TB. We are seeing misinformation, we're seeing cracks along the pathways, which leads us to not getting to where we need to go. So unless we actually tackle the social determinants of inequality, unless we ensure that we've got better vaccines, there are promising vaccine candidates out there, we just need to do more pushing and pulling. If we do not do consistent education, just like we did with HIV, and if we don't push for better etiquette, then we will not get there. We will have to basically still look at having to detect TB when people present at the hospital or at the clinic when it's late, and they don't get psychosocial support when they're sick. And we need to now look at what we're going to do with the comorbidities of HIV and TB and diabetes. There are many things that we're facing within TB infection control. And if we take a holistic approach, I definitely do think that we will get there. Thank you very much for your time. Thank you for listening. And thank you for inviting me to speak on this very important topic.
Hi, everyone. Thank you so much for being a part of this presentation. I really want to thank all the panelists for doing a fantastic job. And I want to thank everybody who has asked questions. They've gotten a lot of great questions in the chat. And I just wanted to throw one out right away. Like, let's just get this ball rolling while we got you guys here. There was a really good question about, and I'm going to throw this one to Ann Ginsberg first, if that's okay. And it was about the difficulties in the development of a TB vaccine. As an advocate, I really want to know how I can help. Watching your slides made me so optimistic. but it's good to know the difficulties as well. So if you don't mind talking a little bit about that, I think it would be really great.
Sure. Thanks, Kate. Happy to. And I'll compare it to the COVID situation because that's a question we get a lot now. Is,
Yeah,
you know, we
hot
got
topic.
COVID vaccines so fast. Why can't we do the same for TB? And there are lots of answers to that. But the ones that are hardest to change are the reasons that really are about the pathogen, the MTB bacteria, as opposed to the SARS-CoV-2 virus, and the nature of the disease. You know, hopefully we can get more money with the help of advocates, funders, governments, et cetera, and more people engaged in the research as it's in such an exciting phase. But we can't change the bacteria that causes the disease, and we can't really change the nature of the disease. So if you think about the SARS-CoV-2 virus, for example, it expresses, I think, 12, roughly a dozen anyway, different proteins. And we already knew from other coronaviruses that the spike protein was crucial to viral entry into cells and was probably needed to be what the vaccine expressed so that you'd get an immune response to the spike protein, and that would prevent the virus from entering and causing disease. TB bacteria, in contrast, express 4,000 genes. And we don't know which of those is necessarily critical for protection. We now know that the two proteins that are in the M72 vaccine candidate must play some role, but we're not getting 100% protection. And so there may well be other protective antigens that should be included in new TB vaccines as well. And we don't yet know what those new antigens are. There's a lot of exciting research that I didn't have time to tell you about today that's providing hints and giving some good candidates, but that those need to be tested now as vaccines and see if they'll do better. And that work is getting underway in a variety of places. There's also the fact that the disease itself, TB disease, has this very long latent period in many people. It's not a rapid infection the way COVID comes, you know, or Ebola or, you know, measles. They come racing through a population. And so, and at very high incidence, which makes it much faster and ultimately less expensive to do the clinical trials you need to do that show that a vaccine is working. The trials for TB vaccines to show whether or not they're working are really exceptionally large and complex and expensive. So that in and of itself takes longer. So I think that those are probably some of the major reasons that TB vaccines just, you know, are going to take somewhat longer than COVID vaccines. But I do think that there's a lot we can learn and leverage from the COVID vaccine situation to help accelerate TB vaccine development above and beyond what we've seen over the previous decades, which has been a pretty slow progress until very recently.
So David, there is a question in the same line about diagnosis. Why development of TB diagnostics are slow, whereas within 1 year of time, dozens of COVID-19 diagnostics developed and available even at POC?
Yeah, that's and I think I'm not on mute. I mean, that's an amazingly good question, and it's a complicated question because it sort of speaks to our field and in some cases, I think our lack of ambition. And I think even going back to HIV, this is another example where we went from Western blots to, you know, point of care saliva testing in a very short period of time. And I think part of that was a willingness to embrace new technologies even before we knew for sure they worked. And my example here would be the tuberculin skin test, which we have been very slow, we still are slow, to sort of move on to newer methodologies. And I think the reason I think that's important is that it's really that movement that drives innovation. And so I think being willing to sort of experiment and try new technologies is really, I think, really important. In this sort of latent TB space, I'm really encouraged about the Cordis trial actually, because we actually do have, I think, pretty decent diagnostics for TB, GeneXpert and others. but we have really have been hampered, I think, for this notion of subclinical or smoldering TB by the positive predictive value of those tests. So the closer we can get to really knowing who's going to go on to get sick, the better off we are. And I think, Lynette, you touched on this beautifully, you know, this sort of this being willing to buy into a therapy where I'm perfectly fine and I have to treat 40 people to prevent one case. So the closer we get to sort of those better predictions, the better we are. And so I don't think the current testing is perfect, but it really shows us sort of the way forward. And I think there's sort of ambition there that could be entertained and sort of really aggressively understanding, like, okay, how could we best predict who's going to go on? And I think it's going to be a little bit like heart disease in the sense that we don't have one test that's perfect, but we can put them together to begin to get kind of an aggregate assessment of risk. So I really love the question. I think there's some ambition there that we as a field, I think, could embrace.
Thank you, David.
Yeah, and you know, thank you, Lynette, for telling your own story. You know, my left lung is totally damaged too. So when I was listening to it, I was like, oh, you know, it was nice to hear the story of somebody else who had been through it. You know, one question that we saw is that healthcare workers frequently say they're overwhelmed by cases and they fear TB resistance, and a lot of times they kind of blame patients. They say they won't complete treatment. And that can make them hesitant even before they start prescribing. There's already this thought that they're going to not want to take the treatment. And how do you think that we can kind of get people to kind of bridge that gap, but kind of fix that connection there? What kind of community outreach do you think maybe we could do? Oh, I think you're still muted, Annette. Lynette, sorry.
As usual, talking to yourself happens quite a lot these days. Thank you very much for the question. I don't blame the healthcare workers for complaining that they are overwhelmed. They really are. And this is because we've now taken this universal health coverage approach, which integrates all of the services under one. But what is not happening is we're not increasing the health workforce. Across all the cascades, across all the donors this year, we've been fighting for human resources for health, additional human resources for health, so that you have community healthcare workers working with healthcare workers to do, for instance, intensified case finding. I think once we fix that problem, we will see better service delivery for all. Because as you know, if you're one person that has to see a target of about 100 to 200 people a day, you're not going to do a good job. So we also need to take care of healthcare workers. The community health approach that we've taken and some studies we've done in the past has been to explain each other's, for instance, to explain what the healthcare workers go through to clients, and then to allow clients to also tell the healthcare workers how they feel, so that there's a bridging of gaps. And what that does is that when we advocate together towards government to say we do need additional healthcare resources. So that is a proactive approach where everybody comes together, nobody blames one another, and we all win. But then the problem is there is nothing that the healthcare workers at healthcare facility can do when there are stockouts. And in many countries, that's what we're facing right now. Thank you for the question.
Can I quickly piggyback on that just quickly, because you talked about stockouts? I know that when we talk about 3-HP and some of these shorter regimens, we talk a lot about like rifapentine. And so is that something that when we have like a shortage of a medication like that, like how does that kind of impact TB care everywhere?
Well, you can guess it does. It will lead to resistance. I'm sorry. And of course, you've got the experts here. David and Anne are better experts than I am. I'm not an epidemiologist. I'm a lawyer by training. So I've got to read like 10,000 documents like you every night just to understand some of this stuff. But from what we've seen is that we are worried about rifampicin for many reasons. But what we do see is within the shorter regimens, when it is consistently supplied and it is consistently taken, then people perform well. But right now we're facing stockouts of rifampicin, and that is because of COVID, number one. That is because, number two, we do not have sufficient manufacturing capacity. So at current point, we've got Sanofi, who's the originator. We've got generic manufacturer, McLeod's, who's now going to produce or is producing the fixed dose combination. And next year, there's going to be another surprise. So at least rifampicin is off patent. And because it's off patent, literally there is, I think, a world of opportunity for us to ensure that we've got higher numbers or higher doses that are going to be developed of 3HP. So we want to get people not even to 3HP. 1HP would be great, so that you're just on treatment for 1 month instead of 3. 3 months is still long, but at least it's not 12 months. So we're trying to reduce the scale. And one day we'll have a pill, and as Anne says, one day we'll have a vaccine, and we'll have one. Thank you.
Just a reminder, while we don't have 3HP for everybody in the world right now, we have an excellent rifampicin-based regimen, which is 2 excellent regimens, which are 4 months of RIF, and that's plenty available, and 3 months of HR, which is also everywhere because it's part of the second part of the active TB treatment. Thank you. Lynette, as we are with you, can I pop another question that came from the audience? Sorry. We asked about the healthcare workers. Now people are asking about the community. How can we better involve TB patients and the community in TB research and implementation efforts? Any specific examples from the Impact for TB project?
Thank you for the question. I think we've started doing a better job in TB in involving communities in a lot of the research. I think in some of the research that David especially mentioned, there was community involvement, heavily involved. And this is in the form of CABs, so the community advisory boards, who are part of the clinical trial, who ensure that they explain what is happening within the trials to community in palatable language, because sometimes, David, we don't understand what you're saying, so it goes over our heads. So at least we do have, we've started improving on that. And within Impact for TB, the reason why I was saying that we've performed so well is because even within the countries that are implementing or are trying to implement 3HP and 1HP regimens, what they've done is that they've involved the community from the start as equal partners. So whenever there's a blockage, whether or not it's regulatory, whether or not MOH refuses to move the guideline process, whether any sort of blockage there is, the community knows what's going on. So they're able to act together as a formalized group. We're pressure points. We've always been pressure points. And I think it's time that what HIV used to do is done in TB. The movement in TB is definitely growing. And it's not only growing because there's more TB survivors, as they call quote unquote TB survivors. I don't like that. And it's because people are just tired, and people are just angry. People who use drugs are angry, immigrants, everybody who is so-called the riffraff of society is tired. So we're all coming together and we're all holding our governments accountable for what is needed. So within the trials, the same thing happens. If there's a trial that's happening in a country where communities don't know, generally there's a red flag that somebody raises, and we do create problems for that trial. In South Africa, as some of you will recall, with the earlier BCG trials the BCG trial that took place last year when COVID hit, there was no proper community consultation and involvement. And that will stop a trial, believe me. So that is how communities can get involved. And as we said, Treatment Action Group does provide training to ensure that we're explaining complex science into language that we also can understand. Thank you.
Thank you, Lynette.
Thank you. I'm sorry we gave you a bunch of questions at once there, Lynette. You were a champ. Thank you. I have one for David now. In the Cortis trial, I hope I'm pronouncing that right, 1% of the walking well had prevalent TB. So that's huge. But moreover, 80% had no symptoms. So how confident would you be to treat without, that diagnosis, those symptoms?
Yeah, no, that's a amazingly great question, Nanette, and really complex, I think. So it was absolutely true. These were not household contacts, just people in various sites, mostly in South Africa, that, just when they did their risk test was positive, and then they turned out to have TB, and the vast majority of them were not symptomatic. And I think it really touches on that sort of spectrum of disease, and I love the fact that everybody had their own take on the spectrum of disease, because it's really saying there is this group of people who really have TB, as far as we can tell, right? They were culture positive, they were asymptomatic, and then maybe they had a lesser bacterial burden than people we might normally diagnose, but that's all about case finding, and they're probably just showing up for care later. So you have this question. I think your question is, if we do the standard latent TB regimen, not knowing even that they actually had TB, what's going to happen? Are they going to get drug resistance, or is that going to be a risk that we worry about? And I think that's a bit of an unknown, right? We do know that the fewer, and Lynette, I apologize if this is, the fewer bacteria there are, the less likely they are to become resistant, even with single therapy. And so the encouraging thing is, over many years, we haven't seen drug resistance emerge with INH, for example. But I think the question is outstanding, and I think it really gets back to really knowing early on, excluding TB in some way before we embark on this latent TB therapy, and trying to do that in the most efficient way possible. And Lynette, I think you touched on that in your talk as well, that sort of spectrum of understanding whether people have TB or not. But it's a wonderful question. And it's really relevant as we begin to talk about doing case finding with these, kind of newer diagnostics. Do we run the risk of sort of just missing TB?
Mm-hmm. We're working on a model to answer that question. And yes, how much do you accept? Yeah, that's an interesting question. But that has a lot to do with what Lynette said in the beginning. So it's not so straightforward as that to say, well, HIV people do not need an X-ray or a TST or any TBI test, and contacts do need. So it's a very complicated issue.
Yeah, so, and Annette, just if I could add to that too, I think this has all been work from Robin Wood and his group in Cape Town, where they've been looking at kind of sophisticated air sampling, and what they find is that, at least in South Africa, the household contact is not necessarily the driver at all. They're finding like the minibuses and pubs and this and that. And so your point is really well taken, that our traditional ways of thinking about risk may not be adequate.
Yeah, I also think that when we'll have a biomarker test, that a signature that really shows us with confidence this is TBI and this is active TB, it will be easier, especially if you have a point of care test like that. That would be wonderful. And there was a question I think you answered already on the chat, but could you share with us your opinions about mRNA-based vaccines for TB?
Sure. No, I think that it's really exciting now to have proof of concept that mRNA can work so well as a vaccine, and the proof of concept, of course, being COVID. And that technology now is being applied to try to develop an mRNA TB vaccine by at least one company, and probably more that I'm not yet aware of. So I think it's really exciting. Again, the challenge is, which antigens do you want to express from that mRNA for TB to have the most impact? And part of the protection from M72 presumably comes from the adjuvant as well, the AS01. And exactly what that adjuvant does, some of the mechanisms are understood, but not entirely. And how to mimic those effects with an mRNA are also not yet clear. So there's still a fair amount of work to do, but we'll at least start being able to evaluate potential mRNA candidates, hopefully within a year or so in the clinic, and get a sense of how much promise there is that can also be a good solution for the TB vaccine field. There was also, I noticed somebody had a comment to my response about why TB vaccines are so difficult, and noted that, I didn't focus on, for exact, the difference in, I think, political will and commitment and funding for TB versus COVID. And those for sure, have been absolutely critical to the rapid progress of COVID vaccines. And, certainly don't mean to diminish those points. So I'm glad this was raised. And agreed, if we could generate the same kind of international political will, leadership commitment, and willingness of governments and others to put in the same level of funding, no doubt TB vaccine development would move faster than it has. No question about it. But I did want to say that alone won't be enough in TB, because there are these scientific differences as well. So while it would certainly speed things up, I still wouldn't expect a licensed vaccine in a year, right, for TB. It's a harder research problem. But certainly faster than it's happening now if we had the same level of political commitment and financial commitment.
Yeah, and to study a disease that developed in a few persons that are infected, and also on such a long-term, needing a long-term follow-up, it's very different from a viral disease, very quickly developing viral disease.
Yeah. But we've shown with the M72 program that it can be done, right? So it's feasible, it's doable. We just have to get out there and keep trying to make that vaccine or other vaccines even better.
We also have a question about acceptability of vaccine, because the COVID-19 pandemics has brought that question to us. In many countries, people just do not want to be vaccinated, and in other countries, we are chasing the vaccine. What do you think about the acceptability of a TB vaccine worldwide?
Well, yeah, I've been impressed because we've now conducted clinical trials of TB vaccine candidates in a number of countries around the world. And of course, we go to the highest burden countries because that is where the vaccines are needed, and that's where you can do the trials most feasibly. And the enthusiasm in the communities, because those trials have all had community engagement and CABs. And the willingness of people to participate in those trials, even when we make it very clear up front that there's no guarantee that vaccine is going to protect them, but that by participating, they will help advance the research. It has not been hard to recruit into those trials. So I am hopeful, and I'm sure Lynette may want to weigh in here, but I'm hopeful at least that given the amazing need for a TB vaccine in the high burden countries, that people in those countries will have a pretty high level of willingness to get a vaccine once it's shown to be safe, of course. So I'd be interested in Lynette's opinion as well.
No, I definitely do agree with you, Anne, but of course my response is not going to be diplomatic, because as much as you do the trials in the high burden TB countries, when something does work, access is not something that we get. Many of our countries still don't have the COVID vaccine, or most of the COVID vaccines. The ones that we are trying with bilateral agreements are not even WHO PQ'd, So I think that is the disjuncture. But again, that is the work of advocates, around doing work around patents, around accessibility, to reduce the price, to ensure that there is equitable access. I think within South Africa, we do know that people are used to being in trials, and they really do want to advance scientific advancement. So in a lot of these countries, people will want to participate for that reason. It's the after effect that happens, I think, that kind of like breaks what the cabs have been doing, because you lose the trust of the community when another trial comes, because the previous one came and the people didn't get the vaccine or the drug, and now you're coming again to test. So they feel as though they test subjects, but they never recipients of those vaccines and care at the end. But I think the situation will turn. We should just keep being positive and work together with pharmaceutical manufacturers to ensure that perhaps through organizations such as the Medicines Patent Pool, we're creating voluntary licenses so that we can get vaccines much faster. I think if we did get it right with the TB vaccine, I'd be the first one to run around the world and just say, just take it, no matter what. I'll find a Bitcoin cryptocurrency way to pay for it. if we got there.
No, I really appreciate your answer, Lynette, and your perspective on that. I guess I'm an optimist, but I have hopes that for TB vaccines, where it's not, the US and Western Europe who really need that vaccine or are particularly interested in it. The goal from the beginning is for those vaccines to be made available at an affordable price to the countries and the populations that really need them. And the funders that are involved in those studies have that as part of their, philosophy and even terms of agreement, certainly in our grants. So, and now some of the manufacturers, which is really crucial, of the vaccines are beginning to stand up and say, we need to develop manufacturing capacity in the regions where there's going to be high burden of disease. So, for example, the CEO of BioNTech recently announced an agreement with the European Union to build manufacturing capacity for RNA vaccines in the Africa region, so that there would be vaccines for Africa, made in Africa, when those vaccines are licensed. So I hope that will serve as a model for other manufacturers as well. And that, we really can sort of leverage the COVID situation to change the way things have been done in the past.
And while we're discussing, preparedness and public health issues for an adult program, vaccination program, what do you think would be the challenges for the governments, given that, if you have a vaccine for infected people, you should have very different timing of vaccination in different populations. Like you have shown us that in China, most of the adult population is not yet infected, and in South Africa or India, almost all adolescents are already infected. So how do you see the preparedness for these different strategies?
That's a great question. And I don't think the countries are well prepared yet. I think it's part of the work that remains to be done. And I do think there'll have to be country level decision making about what kind of implementation program and infrastructure needs to be put in place. Ideally, as I said, a vaccine will work in people who are both pre-infection and post-infection, and then you can give it in whatever the appropriate age group is, say adolescents to adults, to everybody, and not have to test people first to see whether they're LTBI or not. Even if it only works in post-infection and people who do have LTBI, in countries like South Africa, where that's 80% of the adult population, as long as it's safe in pre-infection individuals, you might still give it to everybody, because the challenge of having to IGRA or TST test everyone before you can vaccinate them, it would be a big hurdle, right, to effective vaccination. So a country, as I said, where most of the adults are already infected, you might give everybody in the right age group a post-infection vaccine, as long as it's safe and inexpensive enough. You know, the countries, the finance ministers are going to want to see that it's going to be cost effective, which could certainly be the case for a TB vaccine. Looks like maybe Lynette wants to add something here.
Yes, I just wanted to add that in South Africa they push a lot for the flu vaccine. So there's always a drive annually around, you know, winter time for people to just get their flu vaccines. And I think the same situation would apply, you know, the way that they do, for instance, for children, those vaccines, and the way that they do the flu vaccine, you'd probably have to just integrate those programs, and hopefully that would work. The only thing that has thrown me off as in a country like South Africa, the COVID vaccine strategy hasn't worked that way, and it is. I thought it would be easy because we're used to it. So we do need to think of a middle way model where we do actually, you know, ensure that we are getting the people, because again, it's the so-called urbanized people in urbanized area who think TB is not a thing. So they're the ones that we still need to do a lot of work around, because they're the ones again that have so-called latent TB that present late. Number one. Number two, we need the private sector to work with the public sector. South Africa has got a heavy inequality when it comes to how you access health funding, how you access health services. So when you're in the private sector, you get all the pretty services, you know, everything is all glossy, and they use their own algorithms for everything. Whereas in the public sector, you know, they are using functional models that are coming from evidence-based strategies and the most recent, tests, diagnostic-wise, as well as the vaccines. So we are going to have to do that, as you say, political massaging, number one, but also figuring out how do we merge the two so that we are doing the pre and post vaccination.
Thank you guys all so much for your panels today and all your work. You know, and thank you. It was so interesting to see how so many of you talked about the spectrum of TB disease. I know I think a lot of people in treatment, at least right now, kind of think of things as like latent and active, and don't really. That's not always communicated, this kind of like range of things in between. It feels very new to me, so it's great to hear more about that. That was one thing I really took from today. We have a couple of things that aren't quite like questions in the chat, but it would be nice to hear you guys weigh in on some of the statements people have been making. One person said that better diagnostics and vaccines really need to be accompanied by public health focused intervention. So they're talking about things that I think we kind of use the umbrella term social determinants of health, like pollution, nutrition, poverty. And sometimes it is true that it can be easier to get money for some interventions, but harder to get something like just food, which I think can be a huge, you know, I don't know, these medications make me feel really horrible. I can't imagine, you know, just taking some of them on an empty stomach, you know. And so when I just was curious if any of you guys, I mean, I'm looking at Lynette, but if any of you guys wanted to weigh in on some of these things too. You know, someone else in the chat also mentioned that in their family, TB was considered like a family disease. So when we talk about these kind of, again, social determinants of health, but a lot of times when we use that term, we really mean more like structural inequities is what I kind of think of it more as that. But, you know, either one, if you guys wanted to maybe weigh in on that as we close, I think that would be really nice. Because I really agree with that statement.
Lynette, you want to take that one? So it's a little out of my wheelhouse in a sense, right? It's not something I have any particular expertise in any more than anyone else. But we know for TB that there are lots of cofactors that increase people's risk, right? Decrease their immune systems and make them more vulnerable to TB, and whether that's malnutrition, smoking, diabetes, there are lots of social determinants that impact TB, and probably not enough attention is paid to those yet, and either in research or in implementation. I think certainly the hope is that a vaccine, and so far we don't have any evidence differently, but I would say, again, not enough research has been done, but that a vaccine will work well in people irrespective of their nutritional status. And that's a hope, but we don't have the data yet, right? So very important questions for sure.
David, your insight on that, and Lynette, yes. Go ahead.
I just wanted to say, no, I definitely do agree with Anne. And yes, Kate, it's both. It is the structural, but it's also kind of like, what does happen at within the granularity of the family and the household. I think it's one of those things that we've had issues with WHO with in the past, and I think some of you do know this, the dual standards of if one person within the family's got TB and is on treatment, then the whole family should really be given prophylaxis, right? Irrespective. But that's not what's happening in a lot of our countries. So you'll hear coughing on the child, even though you probably have DRTB or whatever sort of TB that you're carrying. And it's only later that you find out that the child also has tuberculosis. And then, of course, it then spreads that way. But I think what has been really positive has been the work that has been done by Stop TB Partnership in coming up with a whole cascade of tools around rights-based approaches to tuberculosis. So you're looking at it from a family response, but also from a community response. And that what basically means is that you're not only getting psychosocial services in that you're getting food parcels when you're on treatment, but it's moving beyond that and saying who within the government is going to be responsible for the catastrophic costs of tuberculosis on a family. WHO is doing a lot of assessments in countries to quantify these. And with that evidence, Stop TB Partnership has been doing a good job in incorporating those in the community rights and gender strategies, so that we are looking at ways to hold governments accountable to make sure that at least you do know where to go when you do require services over and above the so-called food parcel that you would get at a clinic. At a family level, I do still think, even if, to be honest, we have to do the tuberculose skin test, we have to do the IGRA, we definitely, if one member of the family has got tuberculosis, we can't shy away from the whole approach of putting families on TPT. And I think within Global Fund's new NFM3, the new funding model, Global Fund has ensured that a family approach to TPT is taken, that it's no longer an isolated approach. So I think those are going to be really powerful tools in ensuring that we are moving towards a family-centered response, as well as addressing some of the psychosocial barriers within tuberculosis in the future.
You're on mute, David.
Okay, there we go. Yeah, I feel like I'm like Anne and having no particular expertise, but I think, I think, Anne, and you touched on this in your talk, where you kind of talked about going to the parts of the world where TB was endemic, and we've come to a society where, TB in North America and in Europe looks completely different than TB in Africa and South America, and I think it has always raises this sort of a little bit of a, not a conflict, but a discussion between, do we need new tools, or do we just do what we already know how to do better and with more commitment? And I say that because I showed that graph at the beginning, with what happened in Alaska, same thing happened in the UK. And this was really reflected a real commitment to eradicating TB through public health, through case finding, and you guys, none of us remember this, but there were trucks driving around with X-ray machines. I mean, it wasn't one thing. It was kind of a combination of things. It was much better nutrition, less crowding. All of those things happened, and it clearly worked. And so I think that level of commitment it's really to public health and to TB eradication is what's missing. You know, it's become this disease that nobody wants to talk about. It's a disease of poverty. And Lynette, you're completely right. You know, how can we possibly find TB in a family and not worry about the rest of the family? That kind of question is not okay. So I think to me, it's all the above. You know, and I think to me, COVID highlights that we were willing to invest in diagnostics, to some extent in public health, vaccines, and it was because it was affecting, you know, people who were relatively affluent. And so that commitment to TB, we need to see that. And I think to me, that's what's missing. And I love the idea of vaccines and better diagnostics, but I have to equally love the idea of doing what we kind of know works much more aggressively.
Well, thank you so much. Unfortunately, time is up and we have to close this discussion. Thank you all of you for your excellent presentation. Thank you for the audience for participating. Just as a reminding, this recording will be available to all registered and posted on the ATS website, and it's free for sharing. Look for the next webinar in the ATS site. This is the second of a series of 4. Thank you all for attending, and we wish you good health. Take care, all of you. Thank you so much to the panelists and to the organizers. Thank you.
Thank you. And thanks to the audience for the great questions.
Yes. Thank you.
Thank you, guys.